problem we had yesterday, but maybe today will even be better. So thanks for being back on today. Let me say that for the continuing education hours, please, you that are needing continuing education hours for certification in pedorthics, please contact Betty at the corporate office to have the 10-question test emailed to you so that you can answer the questions and send back in for approval of your credits. At this time, we'll go ahead and get started. This webinar is step-by-step evaluation process, and this process is what you would use if you're going to present at a speaking engagement, whether you're talking on what you're looking for as a pedorthist, or if you're talking on pedorthic approach to foot care issues in a diabetic population or post-polio or sports medicine, anything along that line. This is if you're doing a one-on-one evaluation with someone or a group after the presentation, because a lot of times what I feel like is beneficial if you do give a presentation, and let's say that you are working a booth at the health fair or at the expo, but you were lucky enough to have a 10 to 15 minute to an hour presentation, always set up to do free foot analysis or assessments. And this is the step-by-step process that always worked for me. And I feel like it does bring people into your facility, and it does enhance more referrals. This is, with the expos, a lot of times you would just be doing a booth instead of a presentation, but this is still very important for you to do at your booth. Continue to do it at the national AARP meetings, the diabetic educators meetings, the Army 10 miler, the little people, everything that I have done over the past 3 years in representation for Foot Solutions at expos, health fairs, or speaking engagements. I take time one-on-one and to see the individual that is actually a gift to us for being at the presentation or at the event. Things that I would always consider having and doing at the booth, if you're going to do a free foot assessment, please have them to have their running shoes or walking shoes or daily shoes, and that may be the ones that they have on at this participation. Like if you're doing a evaluation at a home care facility or assisted living or nursing home, then they would have their shoes. Majority of the time what they have on is the shoe they wear the majority of the time. But if you're doing a running event or a walking event for a fundraiser or awareness, they will also have their walking and running shoes with them. I would also have them to bring their old orthotics or over-the-counter insoles that they're using just for the evaluation. I would also have a sign-in sheet for email contacts, residence location for continued contact, and I would also suggest having an area where they would actually mention or take note of the physician that is their primary care physician. That way you could get an idea, let's say within this 15-mile radius, who is the most common orthopedist or family practice or internist or rheumatologist that they see, and maybe go after, contact that physician. Also, which is good, is an X-ray view box for more visibility to the participants. Even if you have a screen, that is visible, it does bring attention to people that are walking by and also people that are waiting to see what's going on. But I used the view box at one time at a facility, a pharmacy location that was new in the area and wanting to do something with the diabetic population. and they invited me to come and give a 10-minute presentation. And we did this 3 times throughout the day. I would give a 10-minute presentation. I was there all day. And they offered free foot assessments. And that brought in patients to me. I also utilized the idea of reaching out to their physician, also saying that I saw a patient of theirs at this time, at this location, for free foot analysis. And these are some of the things that I was aware of. And the view box was very beneficial at the pharmacy site. Also having charts or posters of pronation, supination, knees where they're valgus or varus, is functional leg length, hip charts, anything that would be related to the group that you're going to be speaking at, or that you could use as visible aids in helping to educate them on their specific complaint. PowerPoint presentation, I always like having this if I'm not able to speak, or if I got through speaking and now I'm back at the booth doing analysis or biomechanical analysis. On a laptop, I would always have a presentation either about, and I would suggest Foot Solutions, or something that you have put together as case studies showing different types of issues or diagnosis in relation to knees, hips, low backs, neck, shoulder, and foot issues. That would be very advisable to use for people, especially for people waiting, so that they have something to view before going through the evaluation. Skeletal foot is very important to have for you to explain, because a lot of times we know the bones and the muscles, but a lot of your lay people have no idea as to what bone does this and why is their foot in a pronated position or supinated positioning. And also having different types of materials available, orthotics and over-the-counter insoles, so that you can actually show them the device and they can feel in hand the materials and the weight of it. So this is just an idea of some of the structural alignment charts that you can show. This may be one reason why you're having left hip pain or low back pain. It may actually be stemming from the pronated and hindfoot valgus positioning of that left foot. May actually be causing that left SI joint or the right SI joint or right neck pain. So by having this, and you're taking a picture from the back of their ankle and showing them the positioning of their foot, and then also going to that chart. Let me say, though, that there was a question yesterday is, why would we want to do all of this evaluation at this site? Let me explain to you why it is so important. If people are not coming into your facility, go to the people and use whatever means you have to help educate them and to improve your awareness within that group. A lot of times you may think, well, I don't want to spend that much time with that individual at a booth. Handing out flyers is not going to get it. I think you understand. You've heard me talk about that. You have got to explain what knowledge you have, and they've got to understand what's going on with their foot. And a lot of times, by having that personal contact, they realize this person is genuinely interested in my foot care and within myself. So having a lot of times you got to take a lot of stuff out of your store to your booth to show various things. If you're going to talk different types of materials, have those materials there. If you're going to talk different types of shoes, have those shoes there. Because when you talk about a negative heel with a midfoot support and a great deal of toe spring, a lot of lay people are going to have no idea what you're talking about. But this way you have access to that person, to their analysis, footprint analysis, and then you're showing them the shoe that benefits them. A lot of times what I would do, too, especially when I owned a running shoe store, is that I would go to a running group that maybe was having a lot of running events. They would bring snacks or dinner at night, and they would have a run, let's say a 5-mile run. Then I would give a presentation and then evaluate their feet. But I also took shoes to them, and I sold shoes there. So the orthotics, they had to come into the facility to have the impressions done. But this really brought in a large number of referrals, and a lot of times there was physicians, physical therapists, athletic trainers that was also participating in the events. And it brought me contact to them. So this is priceless time. Let's go to the booth. Like whenever you have a display and a booth format, make sure that your tabletop is not covered with just paper materials. You want something visible. You want to talk what you're about. Okay? So a lot of times taking time to put your hands on the foot, put your hands on their shoes, and evaluate that process. That is priceless. So have a number of shoes, socks, over-the-counter orthotics, or over-the-counter insoles, a custom orthotics, a lot of creams or displays as far as toe separators, toe capsules. These are very, very important to have. And a lot of times, especially with the diabetic meetings that I have participated in, doing a free scanning. And you can see all of these people sitting around waiting to have their feet scanned, going through the diabetic screening. And this is very simple to do. It doesn't take long, but you have had that one-on-one contact with that individual. You're giving them shoe suggestions. You're finding out who their doctor is, at what level is their diabetes, and you learn from them as well as they are learning from you. So, and you can see this group of people that are waiting, and we actually had to go, obtain more chairs to offer a sit-down space or time for a lot of the participants. But we would have, around 15 to 25 people waiting. Now, on the right, you can see the people waiting for the foot screening, and behind is the booth of the Foot Solutions booth. So we are answering questions, and you wouldn't believe how much this drew attention. Free foot screenings brought these people to the booth. So a lot of times you may not have access to your high-tech pressure, foot pressure scanning devices. You may not be able to take these to your booths, but this is where you would spend the time with the foot in hand and visibly looking at the foot itself. Taking your digital camera is very important. That way you can show the individual the positioning of their feet. Also, the pedograph, the Harris mat, is so inexpensive for you to take with you and visibly show the individual. So the time that you spend one-on-one is very valuable. You can see just sitting down here, myself sitting with this couple of the Little People Association, just taking the time to look at his shoes, his feet, a footprint analysis. The DAS system is what we used at the LP convention, which we used a lot of static and dynamic characteristics or evaluation, and it proved to be very beneficial. Also, taking the time to take their shoes on and off and looking at the inside of the shoes, the outside of the shoes, showing genuine concern. But what we did not do here is just give them a pamphlet on what Foot Solutions is. We gave them information, we shook their hand, we took the time with them, and those are just consider yourself. Those would be the people that you would want to go back and see, the people that took time with you. So whenever you do meet people, you want to make eye-to-eye contact. Introduce yourself with a handshake or personal contact and personal approach. Don't just say, how are you today, and stand behind the booth and be afraid to make any contact. Get out in front of that booth. Talk to people. Come across very calm, focused, and assuring. Gather information of history related to injury or chronic problems, being aware of their body language. If they're uncomfortable, try to make them feel more comfortable in opening up. It's not that you're here to just sell them something. You want to help them. You want to become a part of making a difference in their life. If they're making eye contact when you've asked the question, don't detour away from their eyes looking at people walking by. Listen to them. You've asked them the question. Let them answer, and don't assume what you're going to hear. Focus only on the person in front of you. At this booth, you can see the number of people waiting in line behind. They're very in tune as to what's going on in this type of setting. It cannot be a private one-on-one like you would do it with a lot of diabetic foot screening. But in this manner, it was all open. It was a running event. And you're seeing the individual in front, but don't pay a lot of attention to the people waiting in line. Like I said, focus on the person in front of you. They have waited in line or made the effort to see you. Recognize that and appreciate the opportunity that is before you. So I have brought this man over to the side at the same event, and I am explaining to him his pressure scan, and then I will have him walk through doing some dynamic biomechanic evaluation and looking at his footprint analysis. I usually start with the individual after asking questions and doing the scan. I will ask them to stand in front of me, and I will do like an imaginary plumb line down the center of their body. And this will visibly show them the deviation, especially in the forefoot, abduction or adduction, and then explaining to them what their upper torso is doing in relation to that foot positioning. So if they are having knee pain or low back pain, then you're explaining that also makes them more aware and more in tune and more involved into visibly and understanding what their problem is. So in that imaginary plumb line, you can see the plumb line that I have drawn down the center. Just drop the plumb line from the center of his chin, and you can see the rotation in his neck. But you see the center of the chin, there's a great deal of rotation in the cervical area. Coming straight down, dropping that plumb line, then I can see the deviation, how his right foot is deviated away from the midline, where versus the left is straighter. So I know there's a lot more rotation occurring on the right side. And this patient does have a lot of knee issues. So with that involved, that considered, I am explaining to him some of the deviations and the overuse symptoms that could be occurring. Also, while I am visibly looking at this, I'm looking at the earlobes. You can see how the right earlobe is lower, the left earlobe is higher. So I know that there's some external rotation that's occurring on the left side with the earlobe higher and rotated back. So that's occurring in the cervical and thoracic area. Now when that shoulder goes back, you see how the elbow and the hand is gripped tighter and the elbow comes forward. So I'm looking at the crease in the elbows, at the bend of the elbow. There's a difference. This one is tension. So there's contraction of the biceps, where there's less tension of the biceps on the right. So a lot of times with that occurring, with the tension, there is a compensation usually occurring within the body. So it's either opposite or along the core of the hip area. Also with this, just visibly noting the inferior patella site or at the tibia tuberosity, there is a great deal of more rotation occurring, and this one's lower, this one's higher on the right. So I know there is a leg length discrepancy. Also, I just drew a line as far as the pants legs. You can see the pants leg is shorter on the right and longer on the left. Now, that can be hip rotation, that can be a compensation, it can be scoliosis that's occurring. But I'm going to be looking at the anterior iliac crest, also the quadriceps. I'm going to be looking at tone of the quadriceps. So if the pants legs is above the knees or mid-thighs, it offers you more insight from the podorthic evaluation. Patella alignment, I can see that this patella is straighter. The left patella is more externally rotated, which if this patella is externally rotated, you can enhance more compression of patella compression syndrome that may be occurring due to muscle imbalance of the quadriceps, where the vastus lateralis becomes overpowering. The vastus medialis will lose its tone and letting the patella slide laterally. Foot positioning is the instigator of patella issues. I'm also going to be looking at tibia alignment, coming straight down, looking at the tibia in relation to the talus. And I can see there's more rotation on the right than there is on the left. And then looking at foot position. So at another view, a different characteristic, dropping a different individual, dropping a plumb line down the center of his body. Now I see that the left foot is more deviated away from the midline. Okay, in this manner, looking at the end of the shoes, you can see where the N for the New Balance on the distal end of the shoe is different and pointing a complete different direction than the New Balance N on the right. So a lot of times just putting your hand in this manner and touching the end of the shoes visibly shows them the deviation, as well as keeping your hand in this positioning and letting them look down and seeing the abduction away from the midline. Also looking at the hair loss, you can see here on the lower shaft of the tibia. I would ask if there's any type of systemic disorders, circulation, diabetes, anything along that line that may be causing some hair loss. It could actually be due to the type of socks that he's wearing while at work. So looking at this, have the attendees, a lot of times I will have them walk a short distance, approximately 10 yards away from me, and then back toward me, looking at their foot positioning and their biomechanics. If they're wearing long pants, preferably shorts, make sure that the pants cuffs are rolled up to the mid-calf. Don't try to evaluate people with their pants legs not having them roll them up. They keep falling down. You're not going to be able to see the mechanics. So make sure that they roll those pants legs up about mid-calf. Watch their walking characteristics and biomechanics with shoes on, and sometimes I may have them take the shoes off if necessary for more thorough investigation of their issues. If they're having less pain with their shoes on than with shoes off, then you know that they have to have the base support. They've got to have some structural reinforcement. Ask what has been done to treat their issues in the past. Also, at this the expo that I attended here, this is a Diabetic Educators Expo where we had a booth, and I did give a presentation. After the presentation, I was at the booth and did complete one-on-one analysis and footwear evaluation. Also, by showing these educators with a digital camera the loss of base support within their feet and their shoes, gave them more insight and more education on their own benefit, but also showing them the type of shoes, which we had available at the booth, that I would recommend. And then giving them a 10% discount with their footprint analysis to that facility. A lot of times with the shoes, I will do a complete shoe evaluation along with, after the pressure scanning. This is before I really get into evaluating the pressure scan. I want to look at their walk, their stance, their foot positioning with the shoes on, with their shoes off, and now I'm going to evaluate their shoes. I'm looking for, when I set that shoe down up on the table, I'm looking for the positioning that shoe takes on, the toe spring in that shoe, how much elevation is there distally, how flexible is the shoe, is the shoe more flexible in the forefoot versus the midfoot, or vice versa. If the toe box is stiff and the mid-arch is more flexible, I know that shoe is not accommodating their mechanics. It does not accommodate anyone's mechanics. So if you're going to always have a stiff toe box, you have got to have a firm midfoot to help extend and help align and reinforce the mechanics of that foot. Uppers of the shoe positioning, I'm looking for any wear patterns, wrinkles that may be showing me foot characteristics during dynamics, where there's a lot of creases at the first metatarsal, just proximal to the first MTP. If there's a great deal of creasing here, then I know there's not a lot of midfoot support, causing that foot to break down and fall to that first ray to extreme. A lot of times if there's creasing medially and then laterally, the foot is sliding off of the base, then there's not enough heel control. So I want a firm heel control to help with the alignment of that foot. Also, if there's firm heel control and this is still engaging with a shearing lateral, then I know that the foot does not have enough width of the base of the shoe to offer support. So there again, I'm enlightening myself as to what type of shoe will I actually recommend for this individual. I'm looking for heel count or alignment, sole-based wear patterns, how much is the EVA foam compressed, uneven rock of the shoe, if they have worn the shoe approximately 25 to 30 miles, then walking or running or working, within that, if they've worked in that shoe equivalent of 2 months, it's going to show you the pattern that foot is functioning within that environment. So if you lay the shoe up and tap the very back of that spine, just tap up and down with your finger, the shoe will bounce and it will roll or position itself either straight or roll adduction, internal or external, or abduction. That is telling you the position that the foot actually goes into, and that is by tapping the spine of the shoe. Remove the sock liners, always looking at the pressure on the dorsal aspect of the sock liners, and also looking for wear pattern. Look at the style and thickness of their socks, if it's appropriate for their feet. Lacing and laces, and their lacing techniques, and to look at the type of laces that are with it on top of the shoe. So if they're having any dorsal or compression type foot pain, you can show them different lacing techniques. Here again, looking at the compression, the shoe evaluation, the midsole compression, the EVA is no longer reinforcing itself. These shoes, like you've heard me say, these need to be thrown in the nearest garbage. But you can take out the liner of the shoe and showing that the left is the most problematic side with severe pronation, even though if they're not having any foot issues, they're going to have low back or hamstring, fatigue, knee type issues with this type of information. Now, with this chart that I'm going to show you, if you have a chart in this manner, or if you can take a picture of them standing, and this also gives them some visible information themselves. But if you don't have access to that, I'm just showing you what to look at with them standing in front of you. You want to look to see the head tilt. It's tilted to the left or to the right. Their ears, alignment of the ears. You can see the alignment of the ear on the left versus the alignment of the ear on the right. You can see that there's definitely a rotation or a curvature at the cervical area. A lot of times, if your neck is deviated, you're going to see it in the toes. Okay? Don't lose me on this. Now, if the neck is rotated, you can see how elevated the left ear is. Look at the left foot. You see how it's away from the midline? If I drop the plumb line down the center of the body, this plumb line is not just a tip of what I'm looking at is the spine. Okay, and you can see there's curvature in the lumbosacral area, and then dropping a plumb line straight down. But what I'm wanting you to see is that the left ear, you see how much higher and rotated that is, and that positioning, you see how that the left arm is away from the torso, the left foot widens the base and abducts away from the midline. So I just want you to see the correlation of what's occurring on that side, okay? Now, if that foot is abducted away from the midline, can you see how the right arm comes across in front, and that a lot of times you see the tension on the right side in the bicep and in the forearm itself? That's a compensation of trying to tighten up the right side to keep you more stable, to keep you from falling laterally. Because if your left side is deviated away from the midline, the pull of gravity is going to be trying to let you fall to the left. So your right side will become tight and trying to stabilize your center of gravity. Now, open up your mind on this, okay? Just look at it. You're going to think, there's no way I can remember all of this. You've got to learn it in process. Every time you do it, you learn a little bit more. Every time. Every time I do it, everyone is so unique in their individuality that it is very challenging to me, and I love looking at this because it does give me a lot more insight, and I'm educated every time I see a person in doing this type of evaluation. I want to look at the tension at the neck. Now, you can see here that on the right side, the right shoulder seems to be a little lower than the left shoulder, okay? The shoulder drops. It's looking like the left leg may actually be functioning slightly higher than the right leg is functioning higher than the left. It looks almost identical at the iliac crest, anterior iliac crest, but you can see the curvature of the spine. Okay? You can see how the breasts are actually shifted, where the belly button is, and now you can see where the apex is and the concave that's occurring. So you want to look at shoulder height, shoulder rotation, internal, external. Okay? The pectoralis tone, if obvious, and that's these muscles right here. A lot of times you can see a lot of tightness that's occurring in this manner, and that goes along with people that on the opposite side is rotated externally. The pectoralis major and minor will contract, pulling you forward to retain your center of gravity. Now, if that's occurring in the upper thorax, there's a compensation occurring in the feet. That's why working with the feet affects everything above. Arm hang length, bilaterally, we want to see how the arms are hanging, and it tells you how much pressure is on each foot. Which foot is most dominant? Yes, we all have a dominant left or right side. So what I'm looking at is not to see which one is dominant. I'm trying to see how you're standing position-wise and looking at the deviation anatomically and trying to see If this is occurring with this individual, I know on the left I need to have a lot of hindfoot control to help with the alignment of the foot. Okay? Also, with the foot on the left, I want a straight last to a semi-straight last shoe. That offers more control. Muscle tone of the quadriceps, especially the VMO, that's the vastus medialis oblique, and that is this muscle here, the fourth of the vastus medialis, and that oblique is the main muscle that aligns the patella. Now, if you look at the right patella, you can see that we do have a straightness coming down the shin. If you look at the left patella, can you see how that the left patella is coming straight down the medial malleolus? So there is a great deal of stress of the lateral compartment of the knee, along with an impingement. There's a compression at the meniscus and the articulation of the femur and the tibia, and there's an opening or a lengthening or a stretch of the medial compartment of the knee. So a lot of times this would stress ligaments and muscles. On the left, it would compress cartilage of the knee. Now, if this is happening internally, an internal rotation on the knee, on the left, you have external rotation on the left hip. You have external rotation with pronation on the left ankle or forefoot abduction. Okay, so that just, and a lot of times I would just place my hand, pointing my fingers on the left kneecap and my right hand on the right kneecap and then the left kneecap, and letting them look at my hands to show them the angle of deviation. You want to look at patella tracking, that's just what we looked at, as the alignment of the patella. And valgus and varus knees, you can see that the left knee is in valgus and the right is more neutral. Is there genu recurvatum? That's a hyperextension of the knees. It looks like that the left knee would be hyperextended. You can see that the right is straighter. This left knee will pop backwards, or it's hyperextended. Also, with this individual, this is a high school runner. Main complaint is right greater trochanter bursatus, and that's at the hip area on the right side. You want to look at tibia appearance at the inferior patella. And looking at this age group, Osgood-Schlatter disease, and he has always had Osgood-Schlatter disease on the left, but not on the right. The right hip is his complaint at this time. We want to look at ankle alignment. Are they in valgus or varus? Foot positioning, pronation or supination. Forefoot appearance, abduction or adduction. Not necessarily saying everything that you see. Like I'm not communicating with him, I'm drawing a plumb line straight down. I'm letting him know that I'm drawing a plumb line straight down the center of your body. But as you look down, just look at my hand, you can see how the right foot's away from your midline. So I know that the right leg muscles on the lateral side, and here's where he's hurting, is always tight to compensate or to help position that foot. Now, you've got to understand, why is he in that positioning? And it ends up being a leg length discrepancy. But I do not want to say, well, I see your hands are real tight on the right where you're more relaxed on the left. I see your shoulders are at different heights. Your right shoulder's lower, your left is higher. Sometimes I might mention that, but I'm not going to say your ears are weird. Or you can see the difference in your ears and the deviation of the spine. So I am visibly looking at my information to gain more podorthic knowledge. Standing, then I'm going to have him move around, and I want to see posteriorly, standing relaxed, facing the opposite way. And maybe in this contact, you're touching their shoulder, helping to initiate the turn to face away from you. Still personal contact and confidence. Same observation starting at the head as you did looking at him in the front, in the front view. Shoulder height, including tricep tone and arm swing. So I'm looking at elbow height here. I see that the left hand is back, the right hand's forward, so I know that there's a rotation in this manner. And when there's an external rotation of the shoulder, you're going to have more pronation characteristics of the foot. If there's internal rotation of the shoulder, you're going to have more supinated characteristics of the foot. And that's the compensation. The upper torso, looking down at the scapula, I can see that this scapula, you see the wrinkles in this area. There's more of a winging positioning, and that goes along with the positioning of the shoulder. Looking at curvature of the spine, then I will check for posterior iliac crest positioning if I'm thinking there may be a functional leg length. And functional is what we will always look at. We don't have x-ray vision, so we cannot look at structural. Okay? If you anticipate a structural, send them back to the physician. So if it's functional and that is mainly occurring due to pronation, you want to reinforce the pronation first, and then the functional will even out. Because more pronation you have, the shorter the leg functions. You decrease the pronation, the longer the leg functions. So here in palpating bony prominence of the posterior sacroiliac joint, I am just palpating this patient while he's standing on the scan. We've already finished the scan. I want him just to stand still. I'm looking to see where his posterior SI joints are, and then looking at my thumb positioning. Using bony and visible landmarks is very important in looking at the whole process. This is a marathon runner that I've seen with pes anzarine bursatus, and that's medial knee pain occurring on the right. Just looking at her from the posterior view, in my visible scanning, I'm looking at the acromion process. I'm looking at the whole body and evaluating her. I'm not just going from the knees down, okay? I'm looking at the whole body in relation to what muscles actually relates to what part of that foot. So the acromion process, which is the shoulders, there's bony prominence on the dorsal and medial aspect of the shoulders that I'm going to look at. And I might just palpate that area or visibly look. And then I'll look at the inferior border of the scapula. That is below, inferior is below the scapula. And I'm looking to see the height of the scapulas. A lot of times I may touch this area just to look if they have consistent thoracic pain in relation to what I'm looking at on the foot. I'm going to look at the elbows, medial and lateral condyles. This is the lateral condyle of the elbows. And you can see more medial on the left than you see on the right, okay, as far as positioning. So I know that the rotation is occurring. And I can see how the left hand's in front of the hip and the right hand's to the side of the hip. The greater trochanter areas, which is this area, I may palpate this area to see if they have any tenderness, because the iliotibial band is attached to the greater trochanter. And if they're having discomfort down the side of their leg, a lot of time you develop runner's knee, which goes along with greater trochanter or iliotibial band inflammation. Also, I want to look at the femoral condyles, the femur, looking to see the medial aspect of the condyle If it's in alignment or do I see more on one side than the other, then I know there's more rotation on the side that I see more condyle prominence on. I will look at the popliteal space alignment. The popliteal space is this space in this manner. Okay? I am seeing the more rotation that's occurring at the popliteal space. And sometimes I may just put my hand in this manner if I'm showing a parent or if I'm showing another podorthist or an intern, as far as pointing your fingers and keeping your hand at this site in the middle of the popliteal space and the middle of the popliteal space on the right and looking at the deviation. Valgus and varus of the knees. You can see there's a little more valgus positioning on the right than there is on the left, and I think it's due to the forefoot abduction on the right. But this is her painful site on the right. Muscle tone, size, and shape of the gastroc. If you look here, I see a little bit more atrophy on the right gastroc than I see on the left. There's a lot more filling in, especially the medial gastroc. The lateral seems to be a little thicker. Lateral gastroc, and you can see that there's more prominent toning at the lateral aspect of the left than there is on the right. Still, this is the problematic side, and when when this side is being traumatized or stressed, a lot of times muscles will atrophy. Achilles tendon and thickness, I want to look to see the thickness of the Achilles tendon, any bony prominence in the retrocalcaneal area, any thickness, anything that looks abnormal from this state. Also, I'm looking to see where the medial and lateral malleolus is in relation to positioning, and you can see the external or the abduction on the right versus the abduction on the left. On the right, we have too many toe syndrome, so I know there's a rotation that's occurring, so I know that the muscles on the anterior lateral aspect of that side is tightened or shorter, and the medial aspect is lengthened. And this is where her pain is. So looking at and seeing her from behind, you think, okay, you've got a leg length discrepancy. The right leg is shorter. Let's put a lift underneath that right leg. And then all of a sudden, her pain comes back in the back area. And you're thinking, well, that will help with the discomfort that she's having at the knee. Her functional leg length is actually coming from, as you look at her footprint on the right, the midfoot collapse. You see the pronation at the calcaneonavicular and the posterior tib area. And now you see the shift at the calcaneocuboid, the loss of lateral support. This is a breakdown of ankle stability at the talonavicular joint. You can see the shift. Everything seems to be sliding. And that is what's occurring and causing this breakdown and the shortness of that leg. When I reinforce the medial arch, and I did with this type foot, this type of characteristics, you would do a heel cup and calcaneonavicular support, and maybe or maybe not metatarsal support, because she does have all of her toes coming down. It's more prominent on the first metatarsal, but I think it's due to the fact that the navicular has dropped, causing more stress on the first, or more pressure on the first metatarsal. But by reinforcing the calcaneonavicular area, offers more functional leg length. So when I reinforce this area, I don't see this hip drop. Okay? And a lot of times it would change up the popliteal space and the medial condyle alignment. And a lot of times this is why I would suggest taking with you when you're doing an evaluation, if you have time, if you know you're going to be seeing a small amount of people, or small in number, use a skyphoid pad, tape onto the bottom of the foot in this area, and then have them stand. And you look at this area visibly. Is this enough to help reinforce this area? Also, again, checking their footwear, standing. You may have to take a picture of them standing so that you can show them why they need a different type shoe and why this shoe could be actually leading to their problems. So shoe education is a must, and you've got to have the shoes that you're talking about in hand for them to understand. If not, they're going to go down to other sites, and they're going to look for cheaper models, but you're trying to educate them on their shoes. You've done your best. Do your best. If they don't come into your facility, strike it off that you got to meet an individual in this world, and you've tried to help that individual, because 2, 3 more people will come in just from you helping that one individual. With the shoes off, looking at the hindfoot positioning, varus or valgus positioning, you want to look at arch characteristics. You want to look at the navicular positioning and bony prominence. Is there an accessory navicular? Is there a bony prominence mainly at the medial malleolus or lateral malleolus? You can see the bony prominence here at the navicular site. But this happens to be not the navicular bone itself. It is the flexor hallux tendon that is actually bulging in this area along with the posterior tib. So you can see when you palpate that area, you can see that the posterior tib is being stressed. So if you have a chart there or a skeletal model, you can show them what happens when that bone drops down and show them from the knees up why they have so much fatigue in their legs, why they may have cramping in their feet and legs at night, because the muscles are having to overwork to stabilize this positioning. Too many toes syndrome is a no-no. You know that the foot and ankle is being stressed and everything above that site. So looking at forefoot abduction, adduction with this patient here, I can see if I drop the plumb line down the center of the body, I know that that right foot is a little more deviated than the left at the midfoot. Now distally, it's a toss-up, but you can notice that on the left that the great toe is being more flexed and more actively used for balance. One thing is, he cannot, on the right, he has had some gout issues and has set up gouty arthritis and has lost the use of this toe. So it's actually become rigidus. So he is not using that toe to grip and to balance. And that is why he's having to overgrip on the left to balance his center of axis. You can see how that the second toe on the right is all the grip force. And a lot of times when you lose strength within a toe, it will retract back and become totally inactive. The other toes will overpower and take over the workload. Here again, I want to keep in mind, well, while I'm seeing this foot, what type of orthotic would I have to use? What type of shoes would I suggest here? Now, in this type of positioning, with that complete midfoot collapse, also you've got to be seeing what the knee is doing. You've got to look at them from the front and back of their hips to see what is going on there. Is the legs are the legs even at the hip, or the hip height even, or do they have severe scoliosis that's occurring? A lot of times with this, you definitely want to put them in a functional, neutral positioning of making a cast or mole of their foot. If he is rigid, which he is on the right, a lot of times doing a severe supinated positioning for a casting mole like an abs technique is unsuccessful. You have to do more of a neutral functional where you are lining up the knee and offloading the foot as far as pressure and developing that type of impression, or using an STS slipper sock to do this type of compression to retain the medial arch in the manner that you want to accomplish. So looking at for bony deformities, which would be in this area here, and he has no range of motion in the mid part of the foot. It's severe rigid. You want to look at nail color. You can tell tell on the left that there you see how white this area is. That's ischemic. That's a lack of blood flow or a lack of oxygen. You see this a lot in smokers, diabetics, systemic type diseases such as Crohn's or Sjogren's. You want to look for discoloration, thickness, and calluses, edema. Skin texture, is there hair loss? Or are they growing hair on one foot versus the other? You know there's a loss of circulation or other type of reasonings. Retrocalcaneal bursa area, that's looking at the posterior view. You want to look at the bony prominence of the calcaneus. And any callus formation on the calcaneus, whether it be medial or lateral, you know that's where their main contact and main weight-bearing force is. So with this type of foot, I also want to have in my mind a type of shoe already. With that type of rigidus and midfoot collapse, I do not want them in a rocker sole such as a Chongqi, which would actually throw them more into a pronation. I don't want the midsole very soft because I want to reinforce the integrity of that ankle, of that midfoot. So I want a firm base, straight last shoe. And this has to be straight last in order to help in guiding the foot. And it's got to be rigid. So you cannot put them in a very soft, straight last such as the Brooks Dyad. You're going to have to go with something more extreme. The Apex works out very good with the firm midsole, but a true straight last in this manner. Now, sometimes during my profession, I would, especially in running events, I would have a video camera set up, and the runners would bring me their videos or for me to analyze, or sometimes I would video them and break it down frame by frame. And I would look at gait analysis. And I know a lot of times you don't do this, but for those that are very interested in going a step further and getting involved in other active functions, this is very, very beneficial because there's very few people out there that even have the knowledge to do this. So during the gait analysis, I'm looking at head tilt, and this is stopped at a frame. I'm looking at the head tilt in the positioning. I'm looking at the sternum and where his head is located in the sternum. You want the runner to be right over the sternum process, not to be leaning left or right at the neck. If they are leaning left or right at the neck, there's a lot of tension in the upper torso and the arm swing. And with him, you can see that there's more tension on the right than there is on the left. You see how that the head actually is leaning to the right. Now you can see how that the right arm is crossing over the midline of his body. When the arm crosses over the midline, it's a waste of energy. It's causing you to run more vertically, more bouncing, more vertical up and down instead of horizontal. So if I drew a line straight across the top of his head here, and then on my screen, and then watching his running, if he's up and down that line, he's running more vertical. And that's a waste of energy, and it's a compensation of either tight hip flexors, tight hamstrings, excessive pronation, or excessive supination. But with the arm crossing of the midline, you want to keep the arms parallel. There's a compensation. And if he is crossing over the midline in this manner, you know that the hip is externally rotating too aggressive. So that can actually throw more out of alignment. You can see here that is exactly what he's doing. If I drop the plumb line, you can see how that he is crossing over his midline of his body. You can see in this manner. And crossing over the midline, a lot of times he may not have full range of motion of the hips, and it's a compensation. So what would help with this is custom orthotics to help reinforce the medial arch and decrease that pronation to help when he initially contacts the lateral heel, he does not feel like that he needs to bring his whole body across the midline. So I'm looking at hip height during this phase. I'm looking at patella alignment, knee positioning, the stride angle, which I'm going to show you another slide here in just a minute on looking at stride angle, horizontal and vertical angle, which I've told you about, feet parallel or crossover. Feet parallel, you use less energy, you cover more ground. The more you cross over, the more work has to be produced, and the more fatiguing it becomes. You want to look for pronation and supination and the grace of movement. You also want to look to see how tensed his hands are. If his hands are very tense, the thumbs should always rest on the index finger, pointing down toward the ground. Okay, they should never be up, pointed toward the face. The stride angle, looking on the left, and I apologize for this picture not being very good, but I hope that it will give you the idea I'm looking at. In this stopping this frame, I'm looking to see why is this patient always getting shin splints, and looking at the tibia, tuberosity, coming straight down, and you can see now the patella is in this manner. You see how the patella is actually lateral in function. You see more of a medial condyle of the femur. So there is some rotation that's occurring, external rotation, because there's internal rotation at the ankle. Now, when I look at the tibia and draw a line straight down, I can see that the tibia is not setting right over the talus, which that's the way it should be. You should have only 15 degrees of pronation. If we measured this angle coming from this point straight down to the medial aspect of the medial malleolus, you can see that's an increased or over amount of pronation causing stress and overuse. Okay? Also, I can see if I'm looking at is having a lot of IT band, that would go along with this type of characteristic. Also, I want to see where the lateral or the femoral condyle, now remember the femoral is a non-weight-bearing bone, but it's used for attachment, basically, and the support of ligament and tendon attachment. And I can see that that bone, that condyle, is way lateral of the foot base. So that condyle is laterally unsupported. Now, going to the left slide, this is how to measure the stride angle to see if they are covering the amount of ground at each stride that they need to. You're also looking at elbow height, hips, the knees in front, and the knee back. So you start at the greater trochanter laterally, draw a line straight down at the tibio-tuberosity, or the inferior patella, coming straight down that femur, down to the ground. Then you measure from the lateral tuberosity, trochanter, down to the medial femoral condyle, coming down to the medial malleolus. Now, if this knee is forward, then that's what I'm going to measure down the medial. And if it's forward ahead of the foot, then I know there's some instability that's occurring, and there may be some tightness at the hamstring because he wants to run with the knees too flexed. But on the average, a elite runner to a marathon runner, you want a 190-degree stride angle, and you can see this stride angle is not a 90 degrees. This is about a 70 to 75 degree. So I would want to look at hip flexor, making sure that they do have the full range of motion of the hip flexors to help extend this leg further back, and that will use less energy. But they will use less energy if the feet are pronating or supinating extreme. Looking at also another view, compensation, that's all I want to say on the stride analysis. Take that and develop your own, you that are very interested in that. That is my way of evaluating a mechanics and dynamics of a runner. Now, with going back to evaluations during a booth or expo health fair, looking at the compensation techniques or inabilities, you can see that the left hand is higher than the right. You see how the right elbow is forward and the left elbow is back. You can see here on the left, that left shoulder is posteriorly rotated or externally rotated. You can see how the right shoulder is more forward and the left shoulder is higher. And there's a lot more tension and tightness around the scapula, and this is the rhomboid and the trapezius. This is the trapezius and the rhomboid area. Now, looking at their feet in the same manner, you see how the left hand is back, the right hand's forward. So the right shoulder is internally rotated. The left shoulder is posteriorly rotated. With the left shoulder posteriorly rotated or externally rotated, the left foot is pronated more. With the right hand and the shoulder more internally rotated, the right foot is more supinated. And you can see how elevated the first ray is in this manner, and the angle of her knee is more inverted, where the angle of the knee on the right is more pronated. Looking posteriorly, you can see the same characteristics.
Watch the rest of the neck, Donnie.
Shorter.
That chin.
You see the difference in the positioning of the feet. You see the elevation of the first ray. More pronation on the right, less pronation on the more pronation on the left, less pronation on the right. You see the leg length discrepancies here. The left foot's back, the right foot's forward. Also, I wanted to show you a chart on kyphosis. We see more people in this day and time with thoracic and cervical kyphosis. That's a rounding posteriorly, it's a curvature, and that causes a rounded shoulders. It causes less oxygen to get into the lung area. You can see how that the neck goes forward. When the neck goes forward, your toes become clawed. They will overgrip because it's trying to regain or retain center of axis and to help with the gravity pull. Because if you did not grip your toes, your whole body would fall forward. Visible postural alignment, you can see in this manner. I'm looking at a plumb line, drop straight down. I see more toes on the right than on the left. This knee is more hyperextended or genial recurvatum on the left than the right. Look at the difference in the popliteal space. Now, in this view, the same, you see how the left knee is more hyperextended than the right. The right is actually more flexed. If you look straight down on the sagittal plane, you can see what's occurring at the hip and the feet. Doing the foot scan, analyzing the foot scan is so important. Or either using a Harris mat. This is the Lady Professional Golf League that this was in Boston years ago when I evaluated every golfer. When they came off of the course, we did a complete foot analysis on them. And you can see what I had, the Harris mat, and going over with them dynamic and static. So here, a lot of times with just showing them the pressures, let's start breaking this down. Let's go a step further. Establish a center of axis of the foot. You go down in between the second and third toes and make a dot, okay? Wherever the second and third toes are, you come straight down. If they're over here, you come straight down. That's your center of axis. Then you come up the center heel base, just distal of the calcaneus, and make a dot in the center. Now you identify the deviations suggested by overpronation or heel deviation or torque. So if these dots line up to be 0, the foot is imbalanced. If the lines does not line up to be 0, you know that the foot is deviated or torqued. And this helps to establish more pedorthic objectives. Establishes possible correlation with orthopedic issues such as sciatica, which would be in this area, the lateral lumbar area. And you see the pressure here at the medial aspect. That's always a sign of sciatica. Neck pain, you see the pressure at the at the great toe. You see the loss of great toe neck or alignment. That is a great deal of tension at the neck. And then medial knee pain. You can see if that heel is not in alignment with the lateral aspect of the foot, and there's a great deal of deviation, then you know the knee is being torqued. Using a goniometer, very inexpensive, and a lot of the regional meetings I've been doing, we try to have free goniometers for you going through this process. But even if you don't do anything but measure the angle of center of axis, that is giving them some information. And also some information you can give to the doctor. So looking at pressure scans, yes, the pressure is very important looking at this. You can look at the unevenness of the toes. You know that the quadriceps are not the same strength on the right as there is on the left. There's a lot more pressure in the ball of the foot on the on the right. So when I see that more pressure on the ball of the foot and the over-gripping that I see of those toes, I want to look to see, is there anything going on in the thoracic and neck area? Are there more kyphotic in this positioning? Because there's no pressure at the calcaneus. So all the pressure is forward. So I'm going to see what the correlation is with the upper torso and ask questions in that manner. Also, always have a Brannock device or Ritz stick. Because if you anticipate the incorrect fitting of the shoes that they have, show them what they need. Visibly show them. Don't say, well, you've got black toenails syndrome, you've got neuromas, your shoes are too tight or too short. Measure their feet and then tell them. Using a Ritz stick, it's very easy and it's simple and it's easy to put in a bag and take with you. Now, this is concluding the last part. With a lot of senior groups, or if you go to nursing homes or offer a free analysis for retirement facilities, I did a number of retirement facilities, and I went in, those participating, I did each one had an evaluation. Let me mention that unresolved foot problems can have unexpected consequences. Untreated pain often leads a person to move less and gain weight, for example, or to shift balance in unnatural ways, increasing the chance of falling and breaking a bone. So this would always be my focus when I presented to retirement facilities. These are things that I looked at when I did geriatric evaluations. The toenails, looking at the health of the individual. Toenail, and I just want to give you some insight as to why this is so important for you as a Fedorthis and Foot Solutions franchise to open up yourself and broaden your scope of practice, and let's engage in more communication with the health of their feet. Toenails with slightly sunken spoon-shaped indentions, this is so related to anemia, iron deficiency. Often shows up in an unnatural, concave or spoon-like shape to the toes or nail beds, especially in moderate to severe cases. It's caused by not having enough hemoglobin or iron-rich protein in the blood cells that transports oxygen. Internal bleeding, such as an ulcer or heavy menstrual periods, can trigger anemia. More clues, you will see this on the fingers as well as toes. The skin and nail beds both appear pale. The nails may also be brittle and feet may feel cold. Fatigue is the #1 sign of anemia, as are shortness of breath, dizziness when standing, and headaches. Hairless feet or toes is a sign of poor circulation, usually caused by vascular disease, can make hair disappear from the feet. When the heart loses the ability to pump enough blood to the extremities because of arteriosclerosis, Commonly known as the hardening of the arteries, the body has to prioritize its use. Hairy toes are low on the totem pole for this. But hairless feet or toes, Merklu's, can reduce blood supply, also makes it hard to feel a pulse in the feet. So get comfortable checking the pulse on the feet, on the inside, dorsal of the ankle. When you stand, your feet may be bright red or dusky. When elevated, they immediately turn pale. The skin is shiny. People with poor circulation tend to already know they have a cardiovascular condition, such as heart disease or a carotid artery, yet they may not realize they have circulation problems. Frequent foot cramping. And let me go back. The times that I did notice this on a patient, I did note every patient I saw who their physician was at a assisted retirement facility, and I found out who their physician was. And I would just call and talk to their nurse to let them know I saw this patient and I've noticed these issues with their feet. Could they possibly come in, to take a look at this? I'm just wanting to bring this to their attention, and letting them know what I'm going to be doing for this patient. Now, a lot of times I would take shoes to the retirement facility and sell shoes. But I would also go to them to do custom orthotics and deliver custom orthotics. Very seldom did I have them come into the site of practice, but if so, they had to be transported or either brought by a family member. A sore that won't heal on the bottom of the foot is a major clue for diabetes. Elevated blood glucose levels leads to nerve damage in the feet, which means that minor scrapes, cuts, and irritations caused by pressure or friction often go unnoticed, especially by someone who's unaware he has the disease. Untreated, these ulcers can lead to infections and even amputations. Cold feet. Women especially report cold feet. It may be nothing, or it may indicate a thyroid problem. Women over 40 who have cold feet often have an under-functioning thyroid, the gland that regulates temperature and metabolism. Poor circulation in either gender is another possible cause. Hypothyroidism. Thyroidism symptoms are pretty subtle and appear in many disorders: fatigue, depression, weight gain, dry skin. Thick, yellow, downright ugly toenails. This is a fungal infection. It runs rapid below the surface of the nail. This is called onychomycosis, can persist painlessly for years. By the time it's visibly and unattractive, the infection is advanced and can spread to all nails and even fingernails. More clues: the nails may also smell bad and turn dark. People most vulnerable, those with diabetes, circulatory trouble, or immune deficiency disorders like rheumatoid arthritis. When you see a toenail, start asking questions in this manner. Start asking questions about their health. If an older person has trouble walking, sometimes the problem can be traced to the simple fact that an infected nail grows thicker and they're harder to cut, and they simply go ignored to the point of pain. I have seen a number of patients with this type of characteristics. Suddenly, an enlarged, scary-looking big toe. This is probably gout. And it doesn't mean that you have to be over 65 to get it. Gout is a form of arthritis, also called gouty arthritis, that usually is caused by too much uric acid, a natural substance. The buildup of uric acid forms needle-like crystals, especially at low body temperatures. And the coolest part of the body, furthest from the heart, happens to be the big toe. Numbness in both feet. Being unable to feel your feet or have a heavy pins and needle sensation is a hallmark for peripheral neuropathy, or damage to the peripheral nervous system. That means the body's way of transmitting information from the brain and spinal cord to the entire rest of the body. Peripheral neuropathy has many causes, but the top two are diabetes and alcohol abuse, current or past. Chemotherapy is another common cause. Numbness in both feet, more clues, tingling or burning can also appear in hands and may gradually spread up to the arms and legs. The reduced sensation makes it feel like you're constantly wearing heavy socks or gloves. Sore toe joints can easily mean rheumatoid arthritis. A degenerative joint disease is often first felt in the smaller joints, such as the toes and the knuckles of the hands. You'll have swelling and stiffness, and it's usually symmetrical. Pitted toenails. In up to half of all people with psoriasis, the skin disease also shows up in the nail as many little holes, which can be deep or shallow. More than 3/4 of these with psoriatic arthritis, a related disorder that affects the joints as well as the skin, also have pocketed, pitted nails. Now, they may appear yellow or brown or have a salmon-colored patches. Being unable to raise the foot upward from the heel, like if you're standing or sitting down, you may not be able to dorsiflex or to raise the toes off of the floor. This is a signal of dropped foot. It's a nerve or muscle damage that can originate well north of your feet, as far as your back or even shoulder or neck. Certain chemotherapy drugs can also cause trouble lifting the front of the foot while walking or standing. More clues may be pain and numbness as well, though not necessarily. Sometimes the pain is felt in the upper leg or lower spine, where a nerve is pinched by damage or a tumor. In some cases, the foot drags when the person walks. It's rare for both feet to be affected. Report this serious symptom to your doctor, the doctor that they are seeing, that you're seeing this type of symptoms. Now, as a podorthist, there's a lot of things you can do with foot drop. You need a custom foot orthotic. That's usually a UCBL for the alignment of the foot, and you need a rocker sole shoe. But a rocker sole shoe, maybe in a decrease of rocker effect, I would say nothing higher in the angle of plantar flexion of 15 degrees. A 12 degrees or to a 10 degrees is the best for this type of population. Dry, flaky skin, even on the face and hands, may be powdery or dry. Don't dismiss this skin condition on your feet, okay? It's a fungal infection that usually starts as dry, itchy skin that then progresses to inflammation and blisters. When blisters break, the infection spread. Keep the feet dry, including using foot powder in shoes and socks. And this is where the shoes material and the socks have to be evaluated by you. And because sometimes people can be allergic to some of the dyes and some of the synthetic materials inside the shoes. Toes that turn patriotic colors in cold weather. The Raynaud's disease is a phenomenon. It causes the extremity to first go white, then turn blue, and finally appear red before returning to a natural hue. For reasons not well understood, the blood vessels in these areas vasospasm. So that means that the vascular system, the veins actually spasm or overreact, causing the tricolor show. Feet that are really painful to walk on, this could be an undiagnosed stress fractures, and it's a common cause of foot pain. So your feet need to be evaluated. This could actually be an underlying problem, often osteopenia, a decrease in optimum bone density, especially in women over age 50, or some kind of malnutrition, including a vitamin D deficiency, a problem absorbing calcium, or anorexia. Toes that bump upward at the tips. I've only seen 2 of these in my 34 years of doing podorthics. When the very tips of the toes swell to the point where they lose their usual angle and appear to bump upward at the ends, it's called digital clubbing. It's a common sign of serious pulmonary lung disease, including pulmonary fibrosis and lung cancer. Heart disease and certain gastrointestinal diseases such as Crohn's disease are also associated with clubbing. Shooting pains in the heel, we know this could very well be plantar fasciitis. We go through the typical evaluation, but you also have to look at the shoes they're wearing. You go barefooted, you're at a risk. If you're wearing O shoes or flimsy flip-flops, you're at a risk. O shoes is danger, and we want to look at all the shoes. When I would go to a retirement facility or a nursing home, I want to see all their shoes that they have. Majority of the time, they wear house shoes. We have a lot of shoes in the Foot Solutions facility stores that would benefit patients so much better by wearing house shoes, either thin, Akiashis, Ortho-Heel, instead of the little flimsy house shoes they wear. It would accommodate their needs more. Thank you, everyone. I hope that I have brought you some information that you can take and use in your facility daily and take and use with confidence at every exposure that you have outside of your store. Now, these step-by-step, I want you to start using within your facility now with each client and become more acquainted with the process. And then every time you go out, it becomes a natural to you. Now remember, you don't necessarily have to tell everybody what you're seeing, but you're forming information to enlighten your pedorthic assessment. Thank you, everyone. God bless you. Do I have any questions?
Thank you. Please stand by.